Okay, so in this discussion we're going to be basically looking at a review of trauma center designations, but I think before we get to that we have to ask ourselves, what is a trauma patient? Now obviously this severely injured patient seen here from my experience as in a forward resuscitative surgical system in Iraq, clearly this is a trauma patient. But in the civilian setting in particular, these distinctions between a non-trauma patient and a trauma patient can sometimes be a little less clear-cut than this obvious trauma patient who is massively injured. And so in looking at that, I did, as I was preparing this presentation, recruit some help from Dr. Cunningham and Dr. Crow, who did some publicly disseminated work with this in the past, and I think their points made several years ago are still salient and applicable. And then I'm going to share with you some differences, I think, which are bear comment in relation to level 2 and level 1 trauma centers. But back to this question of what is a trauma patient. A trauma patient or a trauma victim is a person who suffered an injury that, number one, poses a significant risk of either loss of life, loss of limb, permanent disfigurement, or permanent disability, and is caused by a blunt or penetrating injury, which would be the most common trauma patients we see. Also, though, you can have patients who would fall into the trauma criteria who have developed their injury or their significant risk of loss of life, limb, etc., due to exposure to chemical or radioactive energy. That would include burns, certainly. Electromagnetic energy, that would include patients struck by lightning, drowning, suffocation, strangulation, or a deficit or excess of heat. So basically your heat casualties during the summer, or your patients with hypothermia, such as a frostbite in the wintertime. Those all fall into the category of trauma, and therefore, if significantly injured enough, would be patients that should be preferentially transferred to a certified trauma center. So let's look more specific at what type of injuries we deal with that make patients trauma patients that should specifically go to a trauma center. It's, for more minor trauma, while meeting the true definition of trauma or the textbook definition of trauma, it is appropriate for some of these patients to be cared for at non-designated trauma centers if the injuries are fairly minor. But what are patients that should go to a trauma center? Well, there's a number of anatomic indicators that would argue for that. Certainly penetrating injuries to the head, neck, or torso are indicative of a patient needing to go to a trauma center. Also, though, if you have injuries to the extremities proximally, so in the thigh or in the proximal arm with any evidence particularly of neurovascular compromise, if you have a visible crush component of the head, neck, or torso, or if there is evidence of significant abdominal trauma from a blunt mechanism, not necessarily penetrating, but from a blunt mechanism, which is severe enough to leave you with a seatbelt sign or evidence of perhaps an acute abdomen on exam as manifest by significant tenderness or distension. The presence of flail chest, that is paradoxical movement of the chest wall inward when the rest of the portion of the chest wall moving inward when the rest of the chest is moving outward, indicative of a portion of the chest which, due to rib fractures at more than one segment along the rib, have left you with impaired ventilation, or evidence of a significant pelvic fracture with the exception of just an isolated hip fracture. These are all anatomic indicators that one should probably consider taking this patient very strongly to a trauma center. Other injuries to the extremities that are a visible crush or have evidence of neurovascular compromise. Certainly traumatic amputations, even if it's not very proximal, if it's just proximal to the wrist or ankle, should be considered. Fracture of 2 or more proximal long bones. Signs and symptoms of spinal cord injury, or patients with serious burns. Serious here defined as 2nd or 3rd degree burns over more than 10%. So greater than 10% total body surface area burns, or any burns involving the strategic areas or the critical areas of the face, airway, hands, feet, or genitalia. Some patients may not have what is an obviously severe anatomic trauma, but they may be very unstable from their trauma or may have evidence of significant physiologic compromise, and that too can provide impetus to transfer a patient preferentially to a trauma center. Here we're talking GCS of 13 or less, patient who's knocked out for more than 5 minutes. Specifically, in looking at the GCS, the most critical component is the motor score. So specifically, some have advocated for a GCS motor score of 4 or less being an independent criteria, even if the overall Glasgow-Coma score is okay or greater than 13 otherwise. Respiratory rate, if the patient's significantly tachypnic or if they are hypoventilating as a result of trauma, not as a result of like a drug overdose or something like that, although those things, as you well know, can be hard sometimes to distinguish in the field. Patients who have a traumatic mechanism and require endotracheal intubation, patients who have or require treatment in the field of a pneumothorax. Obviously, I think that would speak to penetrating injury to the torso, so it's kind of redundant recommendation in that regards. Patients that have some evidence of hemodynamic compromise, specifically hypotension, as defined by a systolic pressure of less than 90 or significant tachycardia with a heart rate of greater than 120. Also, in addition to looking at the anatomic considerations and the physiologic considerations, as I think most of you are well aware of, the mechanism of injury and some other special considerations need to be taken into account well and may favor one transferring a patient to a trauma center. These aren't standalone conditions, but there are sometimes additional factors that may tip you over in that regard. So what are we talking about in regards to mechanism of injury? We're talking about patients who are ejected from the vehicle, rollover mechanisms, patients that it takes you a while to get them out of the vehicle, specifically greater than 20 minutes, have been advocated by some as an indicator that you might consider taking that patient to a trauma center preferentially. Other individuals involved in the trauma who have been severely injured or have died is an indicator sometimes to transport patients as they're at greater risk and sometimes can be hiding significant injuries. Other evidence of a high speed or high velocity motor vehicle crash, if you know that they're driving a highway speed of greater than 40 miles per hour, if there's significant auto deformity, or if there's significant intrusion specifically into the compartment where your patient was at greater than 12 inches. Other helpful things in regards to mechanism of injury, if somebody's struck by an oncoming car, so a car or auto versus pedestrian greater than 5 miles an hour. Same goes for auto versus bicycle, or I would say for a motorcycle. It doesn't really make any sense to me that you would be concerned about a bicycle crash greater than 5 miles an hour, but a motorcycle crash only greater than 20 miles an hour. Certainly if the motorcycle, as far as in somebody getting hit by the motorcycle. Now, if you're getting thrown by the motorcycle, that may be a different animal, and therefore, 20 miles an hour may be a reasonable marker there. Motorcycle crash in which the driver or the rider gets thrown or falls greater than 20 feet. So mechanism of injury is something else to take into account, but should not typically be your sole predictor or your sole discriminator of whether to take a patient to a trauma center or not. Now, when is it appropriate not to take a patient to a trauma center who otherwise meets criteria? If the patient's, the primary one is, as you well know, if the patient's completely crumping on you and you think they're gonna, you're gonna have to code them or something, then in some instances it may be more appropriate to stop at the nearest hospital, even if it's not a certified trauma center. Or if you simply can't get there, and this would be pretty unusual in this area of the world, but if we've got severe weather conditions, or if it's like a mass casualty type of situation and you can't safely transport the patient, if there's some extenuating circumstance that's going to prevent safe and timely transport, then in some instances you may have to divert to a non-trauma center, and that's pretty unusual here on the civilian side. Again, and this would typically be something in a mass casualty situation, either a terrorist bombing type of attack or a severe, natural disasters, things of this nature. If you simply have limited resources in both regards to the trauma centers and in regards to local EMS resources, then it's not going to be, routine protocols that we're following. They're going to be modified protocols, and they're all bets may be off as to where certain patients may need to go. And somebody who's less severely injured, who's not triaged as highly, but still would typically meet trauma criteria, may end up just of necessity going to a trauma center in that setting if there's multiple patients who have more severe injuries. And this really leads into not our discussion for today, but I think it is an important discussion in that how do we prepare for handling mass casualty scenarios while going about our day-to-day, routine trauma care, where we don't have those limitations of, limited resources, limited capabilities, other, risks and stuff. And to be able to move in and out of that is a challenge. We were a little more certainly accustomed to it in the military theater because it wasn't infrequent that we were getting true mass casualties. On the civilian side, much less common, but yet you have to be ready to stand up and deliver and to change your protocols to adapt to that different setting, such as they did in the Boston bombing incident. And then in some other instances, the patient just refuses to go. They've always been cared for at a certain hospital. They want to go there. Obviously, use your judgment on that. But I think we do have to at least listen to the patient. Sometimes, they'll understand if you kind of talk them through that and stuff, but it is a difficult thing if you have a completely lucid patient and they're refusing to go somewhere, and that is something that is acceptable to listen to and to pay heed to. So now, what makes a hospital a trauma center? A trauma center, specifically is a center which has gone through the American College of Surgeons trauma verification. There's 4 levels to this, which we'll get into. But basically, the bare bones of a trauma center in general, be it a level 1, 2, 3, or 4, is that you have immediate availability of surgeons, anesthesiologists, and resuscitative and support equipment on a 24-hour basis. Now, there's differences in how available that is and what immediate really means based upon the level of the trauma center, and we'll talk about that as we move forward. So once again, as per American College of Surgeons verifications, trauma centers are designated as level 1 through level 4. In a major metropolitan area like Columbus, we're essentially talking about level 1 and level 2 trauma centers with a few level 3s smattered in there. One important thing to note is that the differences in levels are based on the depth of the resources available to treat the trauma victim. The differences in levels are not necessarily based on the quality of care, as all trauma centers are verified. They do have to undergo intermittent, typically every 3 years, inspections, and are required to have a commitment to high quality of care. It's just how much emphasis is placed in their center in regards to resources such as education, such as outreach, etc. That really makes the difference between the differing levels. And there are some places in the country, frankly, where there's probably level 3 trauma centers that for certain injuries are as good as level 1s. And there's, I think, and I'm going to make an argument that there's a number of level 2 trauma centers that provide most care as good as level 1s. It's kind of, to me, a little bit like fellowships. Fellowships are extra training that many of our residents get after surgery. And it can, make you a better surgeon in a certain area, be it minimally invasive surgery, hepatobiliary, or whatever. But the hard reality is, if you're a hack of a surgeon who's not a very good surgeon, you can go through a fellowship and still be a hack. Just that one extra year of training, I think society kind of looks at that as, oh, well, Dr. Jones is fellowship trained, so he must be better than Dr. Smith, who's not. Maybe not. If he's a hack going into the fellowship, he may well be a hack coming out of the fellowship, and just because he's got a fellowship after his name doesn't necessarily mean he's better. All things being equal, it is, but all things aren't always equal. And I would argue strongly, and I'm going to present some data to that the same is true with trauma centers. And, all other things being equal, yes, you can argue that a patient is better served at a level 1 trauma center than a level 2 in many instances. At the same time, I know places around the country that meet level 1 designation, but their surgeons, frankly, aren't very good, and those patients in those cities can sometimes be better off going to a level 2 trauma center where the surgeons are better. It may be that the surgeons there aren't as focused on doing research and things of that nature, which is necessary for them to be a level 1 trauma center, but they're actually operating all of the time. The reality with trauma is it's increasingly becoming a non-operative specialty. The majority of trauma patients don't require surgery. And so if you're only doing trauma surgery, a lot of times, frankly, you're not operating a lot. And Andrew Pietzman from the University of Pittsburgh, kind of one of our leading thinkers nationally in trauma, when I heard him lecture at the Detroit Trauma Symposium, I think he's come there a couple times, but I think this was back in 2007, he made the point that all of the trauma surgeons at his center, or the majority of them at least, are general surgeons who have active practices. And he emphasized that he felt that he was a better trauma surgeon because on a daily basis he's in the OR doing liver resections and pancreas resections and gastric resections and things of this nature on an elective basis for surgical oncologic needs and others, and that if he was solely relying on the operative experience he got from doing trauma, he wouldn't be in the OR near as often. And then when the time came to do a very difficult trauma liver case, for example, he feels he wouldn't have the skill set to do that adequately. And so I think sometimes we have to be a little bit cautious to interpret that you're always going to get better care at a level 1 trauma center, and somebody who only does trauma definitely is going to do it better. I think you can make arguments, at least in regards to the operative management of trauma, that many of these trauma patients are frankly better cared for with a general surgeon who's actually operating on these areas on a daily basis, which is much less common with modern trauma management as compared to how it used to be. Okay, so let's look specifically at what the American College of Surgeons distinguishes between a level 1 and a level 2 trauma center. And that's kind of highlighted here. It doesn't project quite as good as I'd hoped, but basically the elements of the level 1 trauma center which are different from that of a level 2 are the level 1 trauma center is expected to provide leadership and prevention, public education in the community. It's also expected to have an organized teaching and research effort with greater than 20 publications over 3 years. That's how often all of us get inspected. And they have to meet minimum requirements for annual volume of severely injured trauma patients, specifically either greater than 1,200 admissions overall or greater than 240 admissions with an injury severity score of greater than 15. In all other aspects, basically the criteria for a level 1 versus a level 2 trauma center are identical. And so there's this perception in the community, not infrequently perpetuated by those that staff level 1 trauma centers, that surgeons aren't in-house and level 2 trauma centers, that they don't have the same operative capability in level 2 trauma centers. And that's just not true. The reality is that the difference between level 1 and level 2 trauma centers are, for the most part, things which aren't clinically relevant. It's more in regards to outreach and teaching and specific minimal volumes. And so, and I take this quote straight out, and obviously I'm a little bit biased. I work in a level 2 trauma center, and I'm not, I'm transparent about that. But, my experience was I felt, as I was in training, I felt a little bit, I'll be honest with you, kind of inadequate in regards to my trauma experience. I felt, well, clearly, people over at Grant are getting better trained and they've got a better trauma center over there. And it wasn't until I was in the military and I had opportunity to spend time at LA County Trauma Center in East LA, which is a war zone in and of itself. We went there to kind of prepare for combat, and I can tell you those people are facing combat there almost on a daily basis with all the gang violence and things you see there. But it was amazing to me as I watched the trauma resuscitations run there at LA County. Quite frankly, I thought in many regards we actually did things better here at Mount Carmel, as contrasted with what's recognized as an international trauma center of excellence at LA County. Now, once the patient got into the operating room and you had Dimitri Dimitriades and George Velmahos and these other world-renowned trauma surgeons operating on, I learned an enormous amount from those guys, and I did and saw stuff that I had never seen before and hadn't seen at Mount Carmel, because these guys are some of the best in the world, and also, by the way, just some of the nicest gentlemen that you would ever care to meet. And I am exceedingly grateful for the time that I had there under their tutelage, and learned an enormous amount. But in the aspects of the initial trauma receiving and the initial trauma care, it wasn't always the best. The ER was kind of at odds with the surgeons and stuff, and despite them being a level 1 trauma center, that aspect of the care we actually did better at our level 2 center. And it was at that point really where those feelings of inadequacy I had for training in the level 2 center kind of started to dissipate, and I really started to see that while there's a lot of great people at level 1 trauma centers, level 2 centers are not by definition inadequate. And the American College of Surgeons resources for optimal care of the trauma patient, kind of the Bible, if you will, of trauma management, specifically says the standards for the provision of clinical care to injured patients for level 1 and level 2 trauma centers are identical. And so the bias that's there in the community, I think, is not accurate in many regards. In regards to level 1 versus level 2, I would argue that your patients are going to be well served at both. So let's look at the data, though. Certainly there is some data in the literature, some of it from my colleagues, my former colleagues at LA County, who again I was privileged to work with, Dimitra Dimitriades, Peter Ree, Carlos Brown, and others. And they did publish this article in the Journal of the American College of Surgeons 11 years ago now, where in looking at level 1 versus level 2 trauma centers in the LA area, the death rate was slightly higher, 15.4 as compared to 14.9 at the level 2 as compared to the level 1. So a slight benefit in outcomes in regards to mortality here at a level 1 versus a level 2 trauma center, which I think would kind of be supportive, although not to an enormous degree, but to at least a slight degree in regards to better outcomes in the level 1 trauma centers. Another study which got a lot of press, not as good a study in my opinion, this was Steve Steinberg's and colleagues here locally at Ohio State, and they looked at, again in this area actually, level 1 versus level 2 trauma centers. And they found that in most areas that they looked at, there was no significant difference. In regards to all of these areas, there was no statistically significant difference in outcomes and survival at a level 1 versus a level 2 trauma center. In the setting of head injury and pelvic fracture, they did in this study, though, reach a statistically significant difference favoring outcomes in the level 1 trauma center. And of course, that was that's what hit the press and everything and stuff. Not that in these regards the outcomes were comparable, but in this regard that the level 1 trauma center was superior, and that was indeed their findings. But is that completely echoed in the literature as a whole, though? And actually a number of patients have not supported this. This was a study that came out in the Journal of Trauma back in 1997, and looking at overall mortality for a number of trauma patients at a level 1 versus a level 2 trauma center. No statistically significant difference in this experience. This paper was a little bit controversial at the time and didn't meet a lot of acceptance, but then their findings began to be echoed by a number of other investigators. This prompted a subsequent review of the level 1 and level 2 trauma centers in a well-developed system in Pennsylvania, where they have a well-developed trauma system. And there they actually found that in 7 out of 9 categories of injury that both level 1 and level 2 trauma centers achieved greater than predicted survival in those areas based upon anatomic and physiologic scoring. Once again, so in this instance, once again indicating essentially equivalent outcomes between the performance of level 1 and level 2 trauma centers, at least in a well-developed trauma system. A subsequent study which showed similar findings, published in the Journal of Trauma in 2001, performed in North Carolina, looking specifically at the subset of severely injured trauma patients, or focusing on those trauma patients with an injury severity score of greater than 25. Once again, between the level 1 and the level 2 centers, we see essentially equivalent outcomes here in regards to the mortality or the fatalities. Another study, which the graphics are a little harder to make out on, but published in the Journal of Trauma more recently in 2011, here looking at basically performance of level 1 versus level 2 trauma centers. The level 1s are in gray here, the level 2s are in black, and essentially what you see is they're equally centered around this line in regards to odds of mortality, such that the outcomes in regards to mortality at both a level 1 and a level 2 trauma center were equivalent in this review. And I think this led to kind of an insightful viewpoint, or an insightful observation, that the common thread throughout these level 1 versus level 2 studies that they comment on in their discussion is that older, more established statewide systems, in those, the net result is that the outcome in level 2 trauma centers tends to more closely resemble their level 1 counterparts. We think, the authors thought, that this was a consequence of the maturation process in trauma system development, and programs that go through multiple 3-year verification visits become facile at understanding what is involved in providing excellent trauma care. This learning curve may be steeper in level 2 trauma centers, where there may be fewer career-oriented trauma surgeons. And I would say in reply to that, but your operative experience may actually be greater in level 2 centers, where you have general surgeons providing more of that because they're actually operating on a daily basis. Here's an interesting study done locally here. Dr. Groner at Children's and a number of local colleagues here at both Children's and at OSU look specifically at mortality within the emergency department in significantly injured trauma patients, and just focusing on, once again, the most severely injured subset of patients, those with an injury severity score of greater than 25, which is the ACS's definition of severe or a very severe trauma. You can see here that the mortality in the emergency department in the level trauma center 1 here being a level 2 trauma center, trauma center 1 being a level 1 trauma center 2 being a level 2 trauma center. You can see that the big cutoff is between these and the other types of trauma centers, or non-designated trauma centers. Statistically significant difference in outcomes here with these severely injured patients in whether they're taken to a trauma center or not. However, in regards to a difference between a level 1 and a level 2, there was no statistically significant difference. As a matter of fact, there was actually a trend to a higher mortality in this study in the level 1 trauma centers, and this is controlled for severity of injury. So actually in this study, not only were the outcomes between the level 1 and the level 2 trauma centers equivalent and vastly better than those in the non-designated trauma centers, but actually the level 2 trauma centers slightly outperformed the level 1s in this study, at least. And so the long and the short of it is that I would argue that, just like with surgeons, it's not so much whether your surgeon has an extra year of training and has a fellowship behind his or her name that's important. It's the real quality of the person and their dedication to what they're doing. And I would argue that the same thing is true of trauma centers. Level 1 trauma centers are tend to be, or for the most part, are a great service to society. But I think the disparity between level 1s and level 2s that most people perceive is not accurate, and that level 2 trauma centers in most instances deliver equivalent care, at least in the majority of areas. And quite frankly, both my own experiences and I believe the literature supports that assertion. I think the most important thing is that you have a well-developed system that follows ACLS guidelines, protocols, and is certified, and the data supports that. In taking your patients to one of these centers, your patients are going to be well served. Thank you.